Thank you. So next we have Dr. Basil, who will be taking the managing macular edema with focal and grid laser treatment.
First of all, thank you, Rohan, for giving us the opportunity to present. So today I'll be talking about managing macular edema with focal and grid laser treatments. So as you know, the laser tissue absorption by the retina, it is important because there are various pigments in the retina, including the melanin and the RPE, which absorbs from 400 to 700 microns. That is the blue, yellow, and the red wavelengths of light. And the xanthophyll, which is present in the inner and the outer plexiform layers of the macula, will absorb the blue light. And so we should always avoid blue light and use green or the yellow lasers. And also hemoglobin, which is present in the blood of the vascular retinal structures, absorb yellow, green, and blue wavelength. So green or yellow lasers are preferred for photocoagulation of vascular structures of the retina. So this was already mentioned, the laser parameters, which includes the duration, interval, spot size, power, etc. So the laser parameters, what we check is the wavelength, the power, duration, and the spot size. And for slit lamp delivery of the laser, contact lenses are required. And the most common is the Goldman 3-mirror lens, which is a plano-concave lens, which gives a virtual erect image and less field of view. But the convex lenses give real and inverted image. And macular lenses, they give high magnification but less field of view. And also it has to be kept in mind the laser spot size we keep on the laser machine gets altered depending upon the contact lens we use. Wide field contact lens, it's magnified, and in macular lenses, it is minified. Now, the prerequisites include the patient consent, adequate pupil dilatation, topical anesthetic, patient comfort, clear contact lens, lubricating material. And the ideal spot size for focal laser would be 50 to 60 microns, and for grid laser would be 100. And the power, it again varies depending upon the media clarity. If there is cataract or PCO or vitreous hemorrhage, the power would be high. And the RPE pigmentation, that is basically in Asians, the RPE pigmentation is very high. So the less power of the laser is required. And also depends upon the machine optic fiber laser media clarity. Now, coming up on the grades of burns, there are grade 1, 2, 3, and 4, which was already told before. So this is the grade 1 laser, which is just a faint blanching, it can be seen. And the grade 2 burns, these are basically used in the grid macular photocoagulation. And coming on to the duration, the conventional laser, we use 150 millisecond, and single spot size is the time to complete the PRP. And the newer ones with the Pascals, it is about a 20 microsecond, up to 25 spots in one single shot can be given. And the advantage is that in conventional laser, there is a continuous delivery of the laser energy to the RPE, and it's transferred to the inner retina, which results in swelling and later scar formation, which involves the inner retina. And the Pascal or the pattern scan laser uses ultra short pulses, and which are about 10 to 20 milliseconds. Whereas the short pulse laser, it is confined to the RP and the outer retina. Therefore, it's uniform, and the small scars in the Pascal will also help in the capillary damage would be less. And coming on to the indication, the anti-VEGF has actually revolutionized the treatment outcome in diabetic macular edema. So as first line, focal therapy and grid laser is reserved primarily for non-center involving diabetic macular edema. So as you know, the grid laser, the another indication for the focal or the grid macular photocoagulation would be clinically significant macular edema. And with the OCT scans, the CSME definition has been slightly changed to new classification, which is the center involving and the non-center involving macular edema. And anti-VEGF therapy has revolutionized the treatment outcome of DNV. So first line of focal and grid laser is primarily reserved for non-center involving diabetic macular edema. So how to do a focal laser? So the ideally 50 to 100 micron spot size is taken, and 50 to 100 millisecond duration, and the power should be just adequate to obtain darkening or whitening of the microaneurysms. And the direct photocoagulation of the leaking microaneurysms on fluorescein angiography, which are outside 500 microns of the foveal center, is done, and there is a direct treatment of the focal fluorescent leaks. And these, the focal laser, the ETDRS has shown that the laser treatment has reduced the incidence of moderate vision loss by 50%. And discrete points of retinal hyperfluorescence or focal leakage that are 500 microns or more from the center of the macula, and the focal leaks, and the laser is done to the focal leaks, which is 300 to 500 microns from the center of macula, or previously treated but CSME which is still persisting, or visual acuity which is 20 by 40 or worse. And these are the pictures showing that faint grade 1 to 2 burns, and this is used to blanch the microaneurysms and closing the leaking microaneurysms. And direct focal laser with green laser of 532 nanometer or yellow laser with 577 nanometer are ideal for direct focal lasers. Now, this is another example. If you can see, following the grid laser, the hard exudate actually, which is here, it's actually reduced following the grid laser therapy. So these are the clinical examples wherein the focal laser have succinate focal maculopathy has been reduced, the macular edema on these OCT scans, as you can see. Now coming on to the grid laser is reserved for diffuse macular edema between 500 microns to 3000 microns from the foveal center. And grade 2 burns, which are 2 burns apart, 100 micron spot size and 100 millisecond duration, and covering the area of the diffuse macular edema outside 500 microns. And for this, green and yellow lasers are preferred. And so this is how a grid laser looks, covering the entire area of the macular thickening outside 500 microns from the foveal center. So the mechanism of action is that the laser removes the unhealthy RPE cells which are replaced by the viable RPE cells, and it destroys the retinal photoreceptors and increases the oxygen consumption, which in turn decreases the blood flow within the leaking vessels. And it simulates the existing RPE cells to absorb more fluid and simulates the vascular endothelial proliferation and improve the integrity of the inner blood retinal barrier. And it is likely that a combination of all these will underlie the efficacy of the grid laser treatment. Now, the complications include the accidental foveal burn. That is, when we are doing a foveal laser, when suddenly if the patient shakes his head, it can result in a foveal burn. And paracentral visual fields loss or scotoma, and the scar enlargement or encroachment to the foveal center, subretinal fibrosis and drop in vision later on. Because of the heavy burns, there can be the scar enlargement, and that will go into the foveal area. And also iatrogenic choroidal neovascularization, also subfoveal migration of the hard exudates is another complication. Thank you.
Thank you, Dr. Basil. Does anybody have any questions?